Part 4, Sclerotherapy Solutions. As a sclerotherapist, you should be aware of other sclerosing agents being administered. This information is provided for background knowledge only and is subject to change. FDA-approved sclerosants: hypertonic saline, which is an osmotic agent; tetradecyl, which is a detergent; sodium morrhuate is also a detergent; and Asclera, recently FDA-approved, is also a detergent. Hypertonic saline. Hypertonic saline has been used in treating small vessels for approximately 20 years in the United States. Concentrations of 10 to 30% have been used in treating telangiectasias, venulectasias, and reticular veins. Available commercially in a 30 ml vial of 23.4% concentration, hypertonic saline may be diluted with lidocaine, procaine, or bacteriostatic water or saline. Hypertonic saline also possesses intrinsic antimicrobial properties, which prevents infection in the treated patients. The mechanism of action of hypertonic saline solution is an osmotic sclerosant which produces endothelial damage via gradient dehydration effect. Contraindication. None known. Anaphylaxis reaction to hypertonic saline are extremely rare. However, excessive amounts of undiluted hypertonic saline will cause sudden hypernatremia and its complications. Dosage and administration. Appropriate sclerosant concentrations for the telangiectasias treatment are as follows. Vessels less than 1 millimeter, you should dilute your hypertonic saline to 11 to 18%. Between 1 to 3 millimeters, hypertonic saline between the concentrations of 20 to 23% may be used. Some sclerotherapists use a 23.4% hypertonic saline solution for all vessel diameters. Patients treated without an addition of lidocaine or the sclerosing solution may complain of pain or burning, which may make them apprehensive about future treatment. Also, when you're starting off doing sclerotherapy as a beginner, we don't recommend that you use a full 23.4% hypertonic saline to treat anybody. The people of Latin, Black, Mediterranean, Asian, Native American, and Middle Eastern descent may have greater propensity for hyperpigmentation. A 15% sclerosing solution of hypertonic saline is recommended when treating these groups to minimize this complication. The current price for a 30 ml vial of hypertonic saline is $1. These are some dilution examples that you can mix your hypertonic saline with lidocaine to create the percentage needed to treat your patients. Tetradecyl is the trade name, is a sclerosing agent manufactured by AngioDynamics. The most frequently employed agent in the U.S. for treating large varicose veins. Sodium tetradecyl is also gaining popularity for treatment in telangiectasia and reticular veins. This is a long-chain fatty acid salt with medium potency detergent properties. Contraindications. They include previous hypersensitivity reactions to the drug, acute superficial thrombophlebitis, valvular or deep vein incompetence, huge superficial veins with wide open communications to deep veins, phlebitis migrans, acute cellulitis, allergic conditions, acute infections, varicosities caused by abdominal or pelvic tumors unless the tumor has been removed, bedridden patients, uncontrolled systemic diseases such as diabetes, toxic hyperthyroidism, tuberculosis, asthma, neoplasm, sepsis, blood dyscrasis, and acute respiratory or skin diseases. Dosage and administration. It is recommended that 0.5 ml is injected into a varicosity and observed for several hours for adverse side effects. Dosage should remain small, usually 0.5 ml to 2 ml. Many recommend only using 1 ml maximum amount per injection. Usually a sclerotherapist will use 5 ml total per treatment session. Maximum single treatment dosage is 10 ml. Strength of the solution depends on the size. Most will be treated with 1%, but larger veins may require 3% solution. The prices are as follows. Sodium morrhuate. This is a mixture of sodium salts and saturated and unsaturated fatty acid of cod liver oil. Contraindications include unusual local reaction at the injection site or systemic reaction that can occur, obliteration of superficial veins in patients with persistent occlusion of the deep veins, acute superficial thrombophlebitis, underlying arterial disease, varicosities caused by abdominal and pelvic tumors, uncontrolled diabetes, thyroid toxicosis, tuberculosis, neoplasms, asthma, sepsis, blood dyscreasis, acute respiratory or skin disease, acute local or systemic infections, and bedridden patients. Dosage and administration. To determine the possible sensitivity to the drug, some clinicians recommend injecting 0.25 or 1 ml of 5% morrhuate sodium into a varicosity 24 hours before administration of a large dose. Dosage of morrhuate sodium depends on the size and degree of varicosity. The usual adult dose for obliteration of small or medium vein is 50 to 100 milligrams, 1 to 2 mLs of the 5% solution injection. The drug may be given as multiple injections at one time or in a single response. Following the injection of sodium morrhuate, the vein promptly becomes hard and swollen for 1 to 2-4 inches, depending on the size and response of the vein. After 24 hours, the vein is hard and slightly tender to touch, with little or no periphlebitis. The skin around the injection becomes light bronze. This color usually disappears shortly. The aching sensation and feeling of stiffness usually occurs and lasts approximately 48 hours. Maximum single treatment dose is 10 mLs. The price for sodium morrhuate is $84 per 30 ml vial. Sodium morrhuate is not one of the more commonly used sclerosing agents. Asclera is a sclerosing agent indicated to treat spider veins and reticular veins in lower extremities that recently got FDA approval. Contraindications. The most common adverse reactions occurring at least 3% or more frequently than on placebo are mild local reactions at the site of injection. Known allergies to Asclera, obviously, and patients with acute thromboembolic diseases. Dosage and administration. For spider veins, Asclera recommends using 0.5%. For reticular veins, Asclera recommends using 1%. Use 0.1 to 0.3 mLs for each injection into each varicose vein. The maximum recommended volume per treatment session is 10 mLs. Repeat treatments may be necessary if the extent of the varicose veins requires more than 10 ml. These treatments should be separated by 1 to 2 weeks apart. Maintain compression for 2 to 3 days after treatment of spider veins and for 5 to 7 days for reticular veins. For extensive varicosities, longer compression treatments with compression bandages or a gradient compression stocking of a higher compression class is recommended. Post-treatment compression is necessary to reduce the risk of DVT. Small intravaricose blood clots, thrombi, that develop may be removed by stab, incision, and thrombus expression. Packaging comes in 0.5 and 1% solution in a 2 ml glass ampule. 2 or 5 ampules are provided in a package. This concludes Part 4 of Sclerotherapy Training Online. Please return to the menu and start with Part 5.